Welcome, everybody. I'd like to welcome you to our webinar. We have some slides to kick this off with. We have a wonderful program today, Interpreting Cardiac Troponins Through the Circle of Life. We have some expert speakers with us today. I'm Dr. Lori Daniels, Professor of Cardiovascular Medicine at the University of California, San Diego. I will be your moderator. I'm joined today by Professor Nicholas Mills from the University of Edinburgh, who has pre-recorded his talk. Unfortunately, he could not be here today. We have Professor Fred Apple from the University of Minnesota, and we have Dr. Amar Jiva from University of Toronto. Experts in troponin, all of them. We're going to kick it off right away without wasting any time. The entire program will take about 90 minutes. We'll have time for question and answer at the end. We're going to be looking at troponin through the circle of life. We're going to be looking at sex differences in cardiac troponins, reporting in troponins throughout age groups, and we're going to have a talk at the end focusing specifically on the clinical utility of cardiac troponins in children, something that has not been written or spoken about quite as much. So very interesting program. And like I said, question and answer at the end. We're going to kick this off with Professor Nicholas Mills from the University of Edinburgh. Professor Mills is the British Heart Foundation Professor of Cardiology at the University of Edinburgh. His research group used linked healthcare data to develop new approaches for the diagnosis and risk stratification of acute cardiac conditions. And he's the lead investigator of a wide series of programs looking into cardiac troponin, a true expert on this. He will be kicking off our first talk. Unfortunately, a video, he won't be here today, but we can still ask questions. And it's about sex differences in cardiac troponins. So may we please start the video for Professor Mills.
So it's a pleasure to join this IFCC webinar. My name is Nick Mills. I'm a cardiologist from Edinburgh in Scotland, and I'm going to tackle the topic of sex differences in cardiac troponin. I'll cover current practice guidelines, a little bit of evidence to support the use of sex-based reference limits, discuss some of the underlying mechanisms, both in health and in disease, and then review some of the clinical studies that have informed our recommendations here before finishing on risk stratification rather than diagnosis. Now, the universal definition of myocardial infarction informs the diagnosis of a heart attack worldwide. The term is used when there's evidence of myocardial injury, which is defined as a cardiac troponin concentration above the 99th percentile upper reference limit from a healthy population in the appropriate clinical setting. This consensus statement has been endorsed by multiple cardiac societies around the world and has undergone iteration since 2000, with the latest edition being published in 2018. And during these iterations, the evidence has accrued to support a recommendation for using sex-specific upper reference limits for high-sensitivity cardiac troponin and for CKMB. The latest review of current or contemporary clinical practice is from a joint initiative between IFCC, EFLM, ADLM, and the European Society of Cardiology. And this surveyed 76 countries from around the world between 2022 and 2023. Across 663 laboratories, sex-specific 99th percentile upper reference limits for cardiac troponin have been implemented in 73% of cardiac troponin I users sites and just 30% of cardiac troponin T sites. So what evidence is there that cardiac troponin differs by sex? Well, first of all, before we review that, I think it's important to highlight that the way we define upper reference limits for cardiac troponin is a little different from some other analytes. For example, we tend to use the 99th percentile rather than the more conventional 97.5th percentile. And this is based on a desire to maintain the specificity of cardiac troponin for a heart attack. There are also very strict criteria on how to define a healthy cohort based on IFCC recommendations. A minimum of 400 healthy females and 400 healthy males should be included. And there are a variety of very specific recommendations to reduce the presence of subclinical cardiac disease in order to define a truly healthy population. This systematic review was published a few years ago now, but it demonstrates that for both cardiac troponin I and cardiac troponin T, the female specific 99th percentile upper reference limit is consistently lower than the uniform 99th percentile. And that's true for both assays. If we continue to use uniform 99th percentiles, we will reduce the recognition of myocardial injury in females, but not males. And this has the potential to introduce bias in clinical practice. Really important. Now, cardiac troponin also varies by age, and you can see here a study from Scotland of around 19,000 healthy persons in the general population, evaluated for both cardiac troponin T on the left and cardiac troponin I on the right, with and without the exclusion of those with a diagnosis of cardiovascular disease at baseline. And what you can see is that the 99th percentile increases with age, and that is true for both troponin T and troponin I, but the sex differences are present at all age bands. On the bottom of the slide, you can also see that the use of a single 99th percentile, as recommended by the manufacturer, identifies an increasing proportion of patients with myocardial injury as we increase in age. And that is true for both men and women, but particularly for cardiac troponin T compared to I. So why do cardiac troponin concentrations differ by sex? Well, I think before answering that question, it's important to highlight that this is true not just in individuals who have troponin measured at a single time point, but it is true across the life course. So in this particular study, cardiac troponin was measured serially through middle age to later life. And you can see that cardiac troponin concentrations are generally lower in women, but that they increase with age. And it takes an additional 10 years for a female in a healthy population to match the troponin concentration of their male counterpart. But interestingly, after the age of around 45 or 50, around the time of the menopause, that increase in cardiac troponin accelerates greater in females compared to males, at least anecdotally suggesting that there is a catch-up phenomenon that may be due to differences in hormones after the menopause. But there are similar differences in the development of cardiac disease. This is a really important study from Sweden called the SCAPA study, where they recruited 30,000 individuals randomly selected from the population between 50 and 64 years of age in order to determine the prevalence and burden of coronary artery disease on a CT scan. The key findings: silent coronary artery disease was present in 4 in 10 persons. The prevalence increases with age, of course, and was twofold higher in males than females when evaluated at the same age. But interestingly, the distribution and pattern of coronary artery disease was identical for both sexes, but the onset of disease was delayed by 10 years in females, mirroring the difference in cardiac troponin concentrations observed across the life course between males and females. But of course, there are also sex differences in the underlying pathophysiology of acute myocardial infarction. So whilst plaque rupture, erosion, and thrombosis remains the dominant cause of a heart attack, and there is a similar frequency of this pathology in both males and females, spontaneous coronary artery dissection, vasospasm, and microvascular dysfunction are much more common in females compared to males. And these differences in the pathophysiology by sex may help to explain why maximal cardiac troponin concentrations are consistently lower in females with a diagnosis of myocardial infarction when compared to males. So if we come back to the definition of a healthy reference population and the upper reference limit, there are likely to be multiple different pathophysiological mechanisms that explain the differences in distribution of cardiac troponin in females and males. Cardiac structure and mass differs in men and women. The influence of estrogens and testosterones may influence cardiac sarcomeric repair and regeneration, and likewise, microvascular health differs as well as does exercise and lifestyle differences between sex. And these add to well-established genetic, environmental, and physiological factors that differ between males and females. What about hormones in transgender patients? Well, current guidelines don't provide clear recommendations here on whether to apply cardiac troponin thresholds based on sex or gender. And in truth, there is very limited evidence available. This is the largest study comprising of just over 1,000 patients with suspected myocardial infarction undergoing testing with both a conventional and then some with a high sensitivity cardiac troponin I assay. And all I can really say here is that myocardial injury was uncommon in this population, and the use of the threshold, which is aligned to gender rather than sex at birth, made a very small difference in the number of patients who would be reclassified, and almost no patients with myocardial infarction were missed whether sex or gender specific thresholds were applied. My conclusion here really is that we need more research into understanding the effects of sex hormones when they're given exogenously on cardiac troponin concentrations in order to really provide clear recommendations regarding the use of sex-specific thresholds in transgender patients. But does the use of sex-specific thresholds have any impact really on clinical care? Well, the clinical studies have a number of limitations. So observational studies comparing different cardiac troponin thresholds in males and females for the diagnosis of myocardial infarction are very challenging to interpret. They have major limitations methodologically. Firstly, cardiac troponin is integral to the diagnosis of myocardial infarction, and almost exclusively care during the conduct of these observational studies has been guided by a uniform threshold that favors the investigation of males over females in clinical practice. Likewise, many studies enroll selected patients with chest pain and have enrolled predominantly male patients, which may not be representative of the patients who undergo testing with a broader range of symptoms in routine clinical practice. That aside, there is some evidence for both cardiac troponin I and cardiac troponin T to inform our practice. This study enrolled 1,000 consecutive patients with suspected myocardial infarction and measured in the background high sensitivity cardiac troponin I. Care was guided by a contemporary assay using a uniform threshold of 50 nanograms per liter during the study. And this study, published almost 10 years ago now, demonstrated that the application of sex-specific 99th centile upper reference limits would result in an identical proportion of male and female patients presenting with possible heart attack having evidence of myocardial injury and a diagnosis of myocardial infarction. Whilst overall there were a larger proportion of males in this study than females, the idea that sex-specific thresholds identify the same proportion with myocardial injury is compelling. The implementation of sex-specific cardiac troponin thresholds in clinical practice has been evaluated in Scotland in just under 50,000 consecutive patients. Interestingly, almost half of all patients with suspected acute coronary syndrome undergoing testing were female in routine clinical practice. Around 10,000 had evidence of myocardial injury, and it's interesting that half of those with myocardial injury were female when using sex-specific thresholds. Despite reclassifying 5 times more women than men on introducing high-sensitivity cardiac troponin into clinical practice, women continued to undergo fewer investigations, to receive fewer treatments than men, and were less likely to undergo revascularization. And therefore, outcomes in this particular implementation were not improved. That's not to say that the recognition of males and an equal proportion of males and females with myocardial injury isn't important, but that we may need to do more than just identify women with myocardial injury in order to improve their outcomes. Similarly, there have been observational studies that have looked at the impact of using sex-specific thresholds for cardiac troponin T. This study, published almost 10 years ago in 2,700 selected patients with chest pain, of which 32% were female, also had marked differences in age between females and males, around 10 years. Women were 10 years older. They report that female-specific troponin T thresholds would reclassify 25 female patients with myocardial injury. That's around 3% of women. Despite most of those women not being recognized in clinical practice as having myocardial injury or undergoing coronary angiography, 2 were reclassified by the team as likely having experienced myocardial infarction. In contrast, the use of a slightly higher male-specific cardiac troponin T threshold only reclassified 2 patients, just 1 in 1,000 men, as not having myocardial injury. Interestingly, there have been very few studies evaluating the implementation of sex-specific thresholds for cardiac troponin T. This is a work in progress and some unpublished data, but it shows you the proportion of females and males who are identified with myocardial injury when transitioning from a cardiac troponin I to a cardiac troponin T assay. When using a sex-specific cardiac troponin I threshold, around 1 in 5 females and males are identified with myocardial injury. With cardiac troponin T, that increased to around 2 in 5 for both females and males, doubling the proportion of patients who are identified with myocardial injury. So here, I think the most important observation is that these assays are not equivalent, rather than that sex-specific thresholds differ between I and T. To add weight to the evidence and recommendations here, 2 really interesting step wedge cluster randomized trials are currently underway in Canada and Denmark, and these will help us understand the impact of lowering the diagnostic threshold for myocardial injury and infarction in women, and to understand what impact that has on subsequent testing and outcomes. I'd like to finish by talking a little bit about cardiac troponin and risk stratification, out with the diagnosis using the 99th centile. A number of different accelerated diagnostic pathways have been developed, validated, and recommended by clinical practice guidelines. The single sample rule-out pathways generally use sex-specific 99th centiles to rule in, but have used uniform risk stratification thresholds to identify patients who are low risk on arrival who could be discharged directly from the emergency department. We recently published this study demonstrating the impact of implementing a uniform rule-out threshold into clinical practice. Interestingly, 81% of females and 81% of males classified as low risk using cardiac troponin were actually discharged from the emergency department, suggesting clinicians were relatively comfortable with risk stratification using cardiac troponin. They were also actually at very low risk, with an event rate of subsequent myocardial infarction or cardiac death at 30 days of 0.09% in both females and males. We took the opportunity in this study to look at the derivation, validation, and evaluation of sex-specific risk stratification or rule-out thresholds, identifying a slightly higher threshold to provide equivalent risk stratification for females and a slightly lower threshold for males. But we concluded that the impact of adopting sex-specific risk stratification thresholds on the healthcare system would be rather negligible, identifying 4 in 100 additional females as suitable for early discharge and 7 in 100 fewer male patients suitable for early discharge. So I'm going to finish with some recommendations for practice. Sex-specific 99th percentiles for cardiac troponin should be used in clinical practice routinely. This will ensure that a similar proportion of females and males are identified with myocardial injury and will minimize the risk of underdiagnosis and underinvestigation of cardiac disease in females. Additional research is definitely required into the effects of sex hormones on cardiac troponin in order to provide guidance on the use of these thresholds in transgender patients. And we also need to do further research to understand whether current guideline-recommended accelerated diagnostic pathways that use high-sensitivity cardiac troponin to risk stratify patients vary by sex beyond the single-sample rule-out pathway. And another recommendation for research is that really we should report the performance for all pathways used in clinical practice in overall and in females and males separately to ensure that we are not introducing bias and disadvantaging males or females respectively. I'd like to finish just by thanking my colleagues that have done a lot of this sex and gender research here in Edinburgh, and in particular to Doreen Kimonai, Cass Lee, and Jasper Bodingas. Thank you for your attention.
Wonderful. Well, we thank Professor Mills in absentia for that excellent talk on sex differences. Our next talk today will be by Professor Fred Apple. Professor Apple is a true giant in the field of biomarkers and troponin in particular. Professor Apple is from University of Minnesota, where he's a professor of laboratory medicine and pathology. He also serves as the medical director of the clinical and forensic toxicology laboratory at Hennepin Healthcare. He's an associate editor of clinical chemistry, a member of the Universal Definition of Myocardial Infarction and Myocardial Injury Global Task Force, and he is on the IFCC Committee on Clinical Application of Cardiac Biomarkers, a true expert and giant in this field, as I said. Professor Apple will be speaking to us now on reporting cardiac troponins through different age groups. Professor Apple, please take it away.
Thank you. I hope everyone can hear and see my slides. My title, as Laurie just said, it's been a fun adventure. Here are some disclosures I'll put up you could have access to. You know, my first slide here is I'm always amazed. I was fortunate once to speak in Padua on the same venue where Galileo talked, and I kind of substituted high-sensitive cardiac troponin T where he had the sun. And we'll come back to that because I think cardiac troponin, we're going to find, has lasted the test of time over aging. So my goals today will be attempt to address observational studies published and provide personal thoughts from years of experience of pros and cons relating whether or not we should incorporate age-related URLs for high-sensitive troponin I or troponin T, in addition to what we have our recommendations for sex-specific URLs in clinical practice. Where will we go in 2026 and beyond? I'm going to drift a little, not drift, but I'm going to talk about what some of the mechanisms, why as we age, do troponins start to show up in greater percentages at higher concentrations as we age. And then I want to consider the future of an exciting novel way troponins being measured, looking at not just a troponin high sensitive IRT, but looking at individual complexes and fragments of troponin. And maybe have a concept is, will this future complex measurement and fragment measurement have an impact on looking at chronic and health and disease, and acute and disease, looking at differentiating type 1, type 2 MI in aging, and also the role in assessment and risk assessment as we age. So listen, as aging, excuse me, as we age throughout our lifespan, we're all living longer. And there's an association now, we've seen in the literature, Nick touched upon that, as aging and increasing cardiac troponins are showing up in the blood. And, what's that from? I know personally, I've been a self-experimental, a self-experimenter, and somewhere around 58, my troponin all of a sudden became measurable above the limit of detection. So we need to look at how all the investigations going on to consider, is there something to add as we age that we should be including as part of guidelines? And we're awaiting, really, Nick Mills is the chair of the new, coming out in 2026, 5th universal definition of MI. So we're all anxiously waiting to see if he and his group, there's a whole new group for the biochemical group for considering biomarkers, what their recommendations will be in addition to sex regarding gender, ethnicity, and here I'm talking about age. So Nick showed something like this, but where do we draw our line in the sand? I mean, right now, our line in the sand, as I'll show you, is pretty specific for diagnosis regarding the 99th percentile, sex specific. I took this picture in northern Minnesota. So my line is it horizontal, or we start to see a line in a vertical range of where we're going to draw lines as far as what we're going to use. So if we take a look at this, in essence, we already know this block looking at the diagnosis is sex-specific 99th percentile related. We do know, as we look at the other boxes, early rule out, as Nick mentioned, high risk, all the cutoffs we're now using for early rule out, let's say high risk, looking at positive predictive value of 70%, are really independent of age. They're age independent. We do know from the literature that risk assessment is age dependent, and the risk does often increase with age. I'm not going to touch on that, but these things we already know. But the biggest thing is the middle box is, should we be implementing age into our evaluation of what we call the apparent reference interval patients we define the sex-specific 99th percentile from. So why does aging cause increases? It's difficult to explain if we are truly healthy individuals. I'll show some mechanistic proposals. There's experimental evidence for alternate mechanisms of cardiac troponin release besides the basic myocardial necrosis we see in, let's say, a type 1 MI, or a blunt trauma that occurs from some type of, let's say, motor vehicle accident. Then there's the controversy is if the troponins we're measuring, whether as we age, is a reversible form, which is controversial, because I've always believed, and the science has always supported directly, an irreversible injury is the reason why myocytes release cardiac troponin, which is predominantly myofibril bound. Then the question I ask philosophically, does it really matter what the mechanism is? Not so much from the treatment point, which is very important, but what the data shows as far as the assessment of an increased troponin and looking at the increased continuum of troponin release, even within the reference interval. When we're looking at these numbers, as far as determining what risk the patient may be and what provider has to address with their patient. This slide is your classic what happens over aging. You have low troponins when we're young, you start to age, you develop chronic disease, troponins start to increase. Then we have our myocardial injury, then we have our acute myocardial infarction. This is what we typically see in practice. And if we look at, there's many studies like this, I'll show you two. This is a paper published by Australian and Canadian group. And if we look at what happens in an age-related non-cardiac pathology admissions, where people came in thinking they might have been having a heart attack, but they were ruled out of any cardiac involvement, you can see somewhere, it's a scattergram, but you can see the density getting much larger, as Nick said, over 50 or 60. And this is looking at a cardiac troponin, when troponin T result, when only overall one value is being looked at. So it's kind of somewhat, I'd say, scary if there is no, apparent cardiac involvement. This is all subclinical. What should we be looking at clinically? And this is just very recent data, unpublished, from a recent clinicaltrials.gov study I did called the MERIT-NI. And you can see here it's plotted a little differently. It's the age on the y-axis. But there's an innuendo, again, the same thing. As we age, we're starting to see cardiac troponin also going up. And this is in patients who presented to the emergency room with a baseline sample for an early rule-out study and never had a diagnosis of myocardial injury. So as Nick alluded to, and I'll go on, the AACC and particularly the IFCC, combined with the AACC Academy, we published this paper in 2018. And we came up with what are expert recommendations, educational guidelines of how we determine how to partition people to develop a 99th percentile. Age, ethnicity, gender, consider biological variation. The sample type could be different, and a minimum of 400 men and women, so appropriate statistics could be included. And this was important, and I'll just show you, this is a busy slide. This is a paper from my group where I tried to add on that we actually had a universal sample bank from the old AACC. And one thing that the previous slide I forgot to mention is all the determinations of the 99th percentile now includes and recommends the use of surrogate biomarkers, meaning if we're trying to eliminate subclinical disease, we've chosen estimated GFR, hemoglobin A1C, and the natriuretic peptide NT-proBNP because of its stability, to use these surrogate markers in addition to a questionnaire and drugs that patients be on to define a better 99th percentile. What we've learned, and we've all known this for years, is that every assay, there's no standardization, there's no harmonization, there's no common calibration. So we're never going to see standardization with assays, even with the universal standard. Every assay has different antibodies and epitopes, and we're going to be seeing many different concentrations. So you have to know your assay to see what percent are measurable for males and females, which is highly recommended that you publish that data to legitimize that your assay is a high sensitivity for now, the metric used, and also the individual concentrations. And we report these concentrations in whole numbers. So let's take a look at a couple of populations. I hope I won't be stealing anything from my next speaker, but the neonatal pediatric populations has been getting a lot of discussion of we should have age-related 99th percentiles. It's a very important population. There's not a lot of data. There's a lot of controversy. You can read through my slide, but what I have learned is that typically in the children's hospitals in Minneapolis I've worked with, they're not so much trying to identify a myocardial infarction, but they're looking for other myocardial diseases and entities. These include myocarditis, some arrhythmias, and cardiomyopathy, and especially also if there's trauma. And they're trying to get a good feel for, is there a signal here that says the heart's been injured? And then the clinician will have to determine what else they're going to do. You know, I picked one Canadian study, Caliber, which I thought it was a nice study that looked at some very young newborns, that it kind of showed that by the age of 3 years, the cardiac troponin concentrations in healthy individuals were quite similar to those found in healthy adults. Now, there's some controversy in other studies that just, again, shows you the complexity of how do you incorporate age and how do you actually identify, especially in neonatals and really young pediatrics, what is normal. The other thing that came out of this is a different study. This in looking at adolescents and U.S. children, the National Health and Nutrition Examination Survey published in 2023. Yes, multiple assays. Yes, different numbers. Yes, different curves. But we all know you can only look at the numbers we have from the individual assay and use those in your hospital and not compare. These data don't surprise me. But again, does it mean we should have different 99th percentiles because there's maybe a 1 or 2 nanogram difference versus what we've already established, mostly in package inches for manufacturers and in a lot of evidence-based literature. So the concept of do we need to develop clinical guidance for the use of high sensitivities in pediatrics, in neonates? And I show this because there's an IFCC Committee of Clinical Applications of Cardiac Biomarkers. This is a paper educational document we published in 2022. I won't read every detail of this, but it does give you an idea that there's a lot of work to be done as far as do we utilize imaging? How do we need to develop robust registries? We need to do them by assay specific, and how this should be incorporated. So there's still work that needs to be done in this population that aren't adults. Now let's look at the adult 1 study. I'll show you a couple studies. There's a lot out there. This is a paper that looked at 3 well-characterized databases, the Dallas Heart Study, Atherosclerosis Risk and Communities ERIC study, and the Cardiovascular Health Study. And what we do see here is just as what we've seen before, is that the 99th percentiles increase with age. They're higher in men, they're males and females. More than 10% of men, in this case, 65 to 74 years, had no cardiovascular disease, as shown in the study, and had cardiac troponin T values above the current myocardial infarction threshold, 14 nanograms per liter. The severe limitation for a lot of these studies I put up here is we've now moved to using these surrogate biomarkers to try to identify the subclinical nature of what's going on, to identify, because all of these, renal disease, diabetes, underlying unrecognized heart failure, were not examined potentially with these surrogate biomarkers, which often can eliminate up to 5 to 15% sometimes of potentially these quote unquote normal people that would not be classified as higher numbers. So again, more work to be done. I came across this one study I thought also was interesting. It was published in 2024. It's titled The Manifestation of Vascular Aging, such as carotid atherosclerosis and carotid arteriosclerosis. It might be related to release of troponin in a population without known coronary vascular disease. As we can see here, from a healthy aging population down through these different diseases, the odds ratio of having an increased concentration and have added risk can go up to as high as 2.66, ranging up to 3.2. So aging is definitely something real here that has effect on our concentrations and does affect our risk. This is just one piece of data from a study we performed just to show you this has nothing to do with aging somewhat as it has to do with males versus females of individuals within the normal range, right? And when you're looking at risk, you could add age to this. What we're seeing here is over a 180-day period that even males and females within a reference normal that presented to the hospital with suspicion, they're not really normal, but you can see it as a 2 to 4-fold higher risk of a major adverse cardiac event. And if you look at the odds ratio, at least from the subset of high sensitive troponin T data, there seemed like there's somewhat protective effect. But when we got over the age of 60, the risk of an adverse event went to 1.7. Now, how does damage occur? We know the typical, this is from 2003, it was a study I worked with a cardiovascular pathologist from UCLA. There's damage to the heart, there's myocardial necrosis. We start to see release of troponin as we reperfuse the damaged part of the heart. The early Paul Collinson rendition postulating what we see when we release, typically it was thought that 98% of the troponin was bound to the myofibrils. There was a cytosolic form. I personally don't believe there's any cytosolic form unless there's been injury. The concept is during the experimental process of trying to look at the different subforms of troponin bound versus free, mechanical stress of releasing from membranes might cause that myocardial form, which led to the initial thought that maybe the cytosol was releasing some forms of troponin that might be reversible, right? And Virginia Van Eyck developed a single sample, small Western blot. And what we see here in this is that, hey, we start off on the left side with single troponin form. And then as we increase, this is troponin I, multiple forms. We know there's oxidation, reduction. This is all what we're seeing in the blood, but there's also things going on in the tissue that we don't have a full picture on to say, is that heart really normal? And just what we see in the blood over time represents, they're both measured 5.8 nanograms per mil. It represents two different pictures of a person of being healthy and maybe some underlying disease. And this is where maybe different approaches and different forms of troponin might assist in helping identify the acute and chronic disease of an apparently healthy individual. So a couple slides I'll show you here. There's a lot of discussion ongoing right now on how we can look at pathways of troponin release using actually measuring complexes, the ITC complex, or fragments of those complexes. And there are three groups that are looking at this. There's the Chinese Mindray group, there's the Finnish group, and there's a group from the Netherlands. And as you read this literature, it's very important, and the IFCC is working on this. Our committee is to try to harmonize the nomenclature. So when papers are published, the nomenclature based on the antibodies being used to measure these will be similar. And the antibodies are really important. And I put that out there because if you know the antibodies, you can detect specific parts of troponin I and T, and we know what we're measuring. And I'll show you this in a recent publication in clinical chemistry. This is the Mindray. They actually have they have automated assays for these forms called high sensitive troponin I. Then you have the long T form of the complex. You have another complex form that includes high sensitivity T. And then they have other forms of long and intermediate. The antibodies are all from HiTest. Mindray owns the company HiTest. It's a subsidiary. So they have a wealth of antibodies they can use to develop these new assays that might assist us, as I mentioned, to determine maybe acute and chronic disease, maybe type 1 from type 2, and follow the kinetics of what's going on in these type of diseases. And I'll just touch on what is the mechanisms, all right? I'm not going to spend a lot of time in this, but possible mechanisms, we've talked about necrosis, then there's apoptosis, programmed cell death, this necropoptosis similar, and just cell wound, right? So these have all been discussed, and there's a lot of discussion and research still going on. A really nice review article, the last one I showed you was from Ola Hammerstedt. This one is from Johannes Meyer and the ESC group. So we need to look at the mechanisms to better understand as people age. Now, the one thing that's a little controversial, and I'm going to show this, there is really no evidence yet that these blebs, which they call them, that are released from cells actually contain troponin. If there's a cytosolic form of troponin, maybe they are in there, but there's a great amount of research that will either talk about, is this true that there could be reversible injury and release into the blood based on the blebs? And then how are mechanisms used to clear these? Now, as we age, clearance does change. And again, this was a nice article published by Ola, looking at discussing, we have endocytosis, we have kidney filtration, we have degradation, and we know aging can and will affect all these. So is it the release of the troponin from the tissue in aging that occurs more frequently from injury or underlying, or are clearances slow down so troponin may accumulate? And this, both concepts has to be considered in when we're looking at aging and determining whether age should be part of determination of 99th percentiles. So a couple final thoughts. Since I first started in this business, I was first lectured in 1980 as a clinical chemistry fellow and learned about proteins. This is down at WashU from one of the most famous biochemists in the world who developed the assay for albumin, Oliver Lowry. And working with cardiologists like Robert Roberts and exercise biochemists who studied this, in my whole experience, I've always had the opinion based on the evidence that the troponin we are seeing is not reversible, it's irreversible. Now, does aging impact release and mechanism? I think I just mentioned 100%. Getting older is not fun sometimes. Evolving pathophysiologies are responsible for our increases in troponin. I'll have to leave it up to my internal medicine doctor to make the decision as my troponin leaks up. Does it actually mean anything? And does this warrant that age or decade-related sex-specific URLs without the use of surrogate biomarkers or imaging and medication use should be put into practice? I personally would not recommend it at present. Yet I'm anxious and interested to see what the fifth universal definition will touch on. And my last slide, I'm going to show you here as a fun report. This is something I worked with some anthropologists. They approached me. This shows you the test of time that troponin in aging, it still works. This happens to be a mummified individual, Horem Kensia. I can't even pronounce his name. Horem Kensi. He was a craftsman of decorating tombs of the pharaohs. We're talking 3,000 years ago. He was a well-known priest, and he was known to make frequent mild journeys in the archives kept in the desert, which they found him in the desert. And the forensic study of his mummified body indicated that he was about 60 years old. He likely had fell down in the sand, was heavily infested with beetles before mummification. And he, based on some records they found, he might have had some underlying heart conditions, and they thought he died of sudden cardiac death. I was given some tissue with some controls. This is kind of a fun project we did. And you can see we were able to look at the epitopes of cardiac troponin I, that the mummified tissue from this individual thought to have heart disease was significantly higher nanograms of troponin per gram of tissue compared to mummified controls that were all less than 1 nanogram. So the data suggests here preservation of diagnostic epitopes allowed, in this case, the determination of myocardial death, even several thousand years after. And I put a little LOL after that because the concept of aging is real, but how we put them into practice as far as the URLs will be up to the experts and the evidence. But the bottom line is troponin is around to stay. Thank you very much, and I look forward to answering some questions later if there are any.
Fantastic talk, Fred. Thank you so much. Very interesting and thoughtful questions and comments at the end, which I'm sure hopefully we'll have time to get into later. We'll move on to our third and final presentation now on the clinical utility of cardiac troponins in children. We have the pleasure of having Dr. Amar Jiwa today to present with us. Dr. Jiwa received his medical degree from University of Dublin in Ireland, and then pursued training in pediatric cardiology. He did a clinical fellowship in heart function and transplantation, and he has served now since 2018 as the medical director of the ventricular assist device program at the University of Sick Kids, the Hospital for Sick Kids. I apologize. Dr. Jiwa's research interests include cardiomyopathies, ventricular assist devices, myocardial recovery, and pediatric heart failure and transplant outcomes. So he's quite an expert in the world of pediatric hearts, especially the sickest of the sick, and no better person to speak to us about cardiac troponins in children. Dr. Jiwa, please take it away.
Thank you for that introduction, Dr. Daniels. I'm just going to share my slides. There. Okay. Good morning, good afternoon, or good evening, wherever you may be. I want to thank the IFCC for this opportunity to present on some of the clinical utilities of cardiac troponins in children. And I think Dr. Apple gave some really nice background information about some of the data and as well as challenges with regards to cardiac troponins in children. In brief, I'm going to just use a case-based examples to highlight the various indications of troponin use in children. And I will provide examples of appropriate use versus some more nebulous indications for troponin testing in children. And I'll preface this to saying that this is still an area where there's a paucity of data beyond kind of large normal population upper reference limit data available in troponins. As Dr. Apple had kind of alluded to in his talk, some of the challenges that occur really come down to the varying types of pediatric heart diseases, different ages, and different clinical contexts for troponin use in children. So I'll begin with my first case, which is an athlete with sudden collapse. So you can imagine a 17-year-old basketball player, a competitive high-level athlete, no previous cardiovascular-related symptoms, no family history of early myocardial infarctions, congenital heart disease, or arrhythmia. He was running on the basketball court, stopped, clutched his chest, and collapsed. Received bystander CPR and was successfully resuscitated and transferred to hospital for further evaluation. He underwent the differential diagnosis of this would include conditions like hypertrophic cardiomyopathy, arrhythmias, like long QT syndrome, subclinical myocarditis, and possibly a coronary artery abnormality. And so on exam, you'd see the overall normal physical exam during the emergency room evaluation, chest radiograph showing normal cardiac size and clear lung fields, sinus rhythm on his ECG with some T-wave inversion, which can be a non-specific finding in a normal QTC, which would rule out arrhythmias like long QT syndrome. An echocardiogram that shows normal chamber sizes, no evidence of thickness like hypertrophic cardiomyopathy, normal function, but the left coronary artery was just not seen by echocardiogram. A troponin that's elevated, and you can see that it's 100 nanograms per liter, and the normals are usually less than 30 for troponin I in our institution. And then CT angiography was done because that left coronary wasn't seen, and what they noted was a left coronary artery arising from the right coronary artery sinus with what we call an intramural or interarterial course, and I'll show that a little more clearly. So this is the ECG showing those T-wave inversions, and again, these can be non-specific findings and not always associated with abnormalities. And this is on echocardiogram what we actually look for when we talk about coronary artery anatomy. So the aorta sits in the middle in this particular echo view, and we look at the left coronary artery arising normally and the right coronary artery arising normally from the right sinus. And this is what we would typically see if we see them well by echo. And there are times when we, due to body habitus or size or various reasons, we can't see the coronary arteries well. We can perform angiography, and CT angiography is one of those ways. And so this is just a CT image showing not the nice kind of open, clear opening to the left coronary artery, but one that has more of a slit-like entrance that's tapered and also then is compressed between the aorta, which is the round circle here, and the pulmonary artery, which is the vessel adjacent to it. And so that the left coronary artery can not only be narrowed, but also compressed by another structure. And so this leads into diagnosis of what people call anomalous aortic origin of the coronary artery, or AAOCA. These are rare congenital anomalies, but have been implicated in sudden cardiac death. As you can see, the prevalence is about 0.4 to 0.8, with an abnormal left coronary artery being more common than an abnormal right. They can be diagnosed by echocardiography and CTA, or stress perfusion imaging. And the management does depend on the severity of the lesion. And so the left coronary artery from the right sinus is a worse or more severe lesion, which is more often associated with sudden events or chest pain or ischemic events, versus when a right coronary artery comes from the left side or the left sinus. Those tend to be not completely benign, but much less likely to be symptomatic or less likely to be related to sudden cardiac death than abnormal lefts. This can be medically managed. That often takes into what type of activities the young person is doing, and if they're athletes versus non-athletes. However, surgical correction is done for high risk lesions. And that's moving the coronary artery or opening up the narrowed regions. And so in this case, troponin adds to the initial diagnostic workup and suspicion for coronary artery abnormality, especially in a patient that presents with a sudden cardiac event. But there's probably little role for serial testing in this case. So you've identified that there is a congenital anomaly to the coronary arteries, and troponin will have guided you in making that decision or that diagnosis of that decision, but it's not really going to help you to keep trending the cardiac troponin thereafter. Before I go to the next case, and I don't mention this, but I shall mention this kind of now, is that other coronary artery lesions will benefit from troponin testing as well too. So things like Kawasaki disease, where those with complex Kawasaki disease will have coronary artery enlargement or aneurysms develop. And again, this is where troponin may also add some role in making the diagnosis of the coronary artery lesion, but may also be a bit challenged in with regards to interpreting what serial data means in those particular lesions. A second case is one of chest pain presenting to the emergency rooms. This is very common. However, it's more, or I'd say it's less common in children, and more often than not, and about, I would say 99% of the time, chest pain in children presenting to the emergency room is usually not cardiac. So it can be musculoskeletal or other reasons, but tends not to be cardiac in cause. So this is a 14-year-old patient who received a COVID-19 vaccination 1 week prior and presents to the local emergency room with chest pain. Now, this is a fairly common scenario during the pandemic, when people were getting their COVID vaccinations, and especially in young individuals. This is a previously well individual with no cardiac or other chronic illnesses, but did get hit with a baseball in the chest last week. Received initial dose without much concern other than some mild myalgia, is afebrile, but has a diffuse chest pain without radiation. The ECG shows diffuse ST segment elevation, so this can be seen in myocardial inflammatory conditions. And you can see here, this is a very markedly elevated troponin I level here. The patient was admitted for observation, and then the differential is going to include conditions like myopericarditis, a COVID vaccination adverse event, and because of the chest wall injury or the trauma to the chest, commotio cordis would be a possible diagnosis as well. See here the ECG that I've put up and highlighting the areas there's diffuse ST segment elevation in this young individual. Again, this is not typical of what we would see in myocardial ischemia, and especially in this age group, but can be seen more often in cardioinflammatory conditions. And these echocardiogram clips will briefly show that in this young individual with an elevated troponin, the clips are going to be a little bit stalled. I can keep playing them. Show decreased ventricular function here, especially this is the region of the left ventricle. And the left ventricle is just not as squeezing as happy, and maybe even in context when you compare to the right side, it's just not squeezing as well as the right side of the ventricle. And so there's decreased myocardial function here in this case as well. So as I said, it's unlikely to be commotio cordis, and mostly due to the timing of that chest pain being 1 week prior. That tends to be more of an immediate or kind of early onset condition. And we did see episodes of pericarditis and myocarditis, whether it was related to COVID infection, but we also had seen those cases after COVID-19 vaccinations. Some of the data did show that it was more often related to one particular type of vaccine over another. There was also a predominance in either teenage or young adult males versus females. The majority of these cases were self-limited. Reports of patients with decreased cardiac function or changes seen on cardiac MRI, and there's a number of small studies, but a number of studies that did show this. Serial troponins decreased in this particular patient during the hospitalization with normalization on ambulatory follow-up. So it went from about 16,000 to about 13,000 within a 24 to 48 hour period. And then about a 1 or 2 week period later, it was down to 44. So near normalization of the troponin level. And then when we came down to, at the time, talking about future COVID-19 vaccinations, we recommended guidance from our special immunization clinic. And many of the children who had any kind of cardioinflammatory response were sent to our special immunization clinic just to determine any further risks from the next vaccinations. And so, post-COVID vaccination troponin elevation was an entity. It's very hard to really know what exactly it is. The CDC guidance on the post-COVID vaccine myocarditis or pericarditis was that to consider myocarditis and pericarditis in persons with acute chest pain, shortness of breath, or palpitations. Younger children may have kind of non-specific symptoms of irritability, vomiting, poor feeding. That's how often cardiac disease can present to children. And then for initial evaluation, consider an ECG, troponin level, and inflammatory markers such as a CRP or ESR. And they do comment that in the setting of a normal ECG, troponin, and inflammatory markers, that the myocarditis or pericarditis associated is unlikely. And I've kind of highlighted just a number of studies here that were, again, many of these are kind of small data sets, but showing the association of COVID-19 vaccination myocarditis, and some of them depict the changes on MRI and the late gadolinium enhancement that was seen. There are some who kind of felt like this is a very different entity from wild type or viral myocarditis, and that the troponinemia is short-lived. The kind of long-lasting cardiac involvement seems to be unlikely, but there truly was a cardioinflammatory component to this vaccination. And as an aside, when we talk about troponin and viral myocarditis, cardiac troponin are sensitive and specific markers of myocardial injury, and their elevated levels can be seen in about 1 in 3 patients with myocarditis. Elevated troponins may also be seen in subclinical myocarditis, and serial testing may have a role in the defervescence of the disease, or as well in response to immunomodulatory therapy. And how you treat myocarditis varies very much from center to center and probably country to country. And there are those that will use immunoglobulin therapy or steroids and monoclonal antibody therapies for more refractory cases. But there is also centers that actually don't use any of these things and just do supportive care therapies for myocarditis. And this graph here showing the changes in changes in troponin levels. You can see that myocarditis episodes can be similar to that of someone running a marathon or having a non-ST segment elevated MI. So often presenting in kind of the more moderately elevated groups of, and this is troponin T, but of troponin elevations for patients presenting to emergency room. My next case is an infant with respiratory distress. And so this is a 2-year-old infant with trisomy 21 and tetralogy of Fallot post-surgical repair as a 7-month-old. The post-surgical repair period was complicated by a prolonged hospitalization and heart block needing a pacemaker. And now it's, many months later after surgery, but the patient presents to the emergency room with respiratory distress secondary to an RSV infection. It's wintertime, so this is a common presentation. They have tachypnea, tachycardia, and hypotension. The ECG shows sinus tachycardia with a right bundle branch block. This is a common finding that we see in children after congenital heart disease surgery, but it also makes it tricky to look for ST segment elevations because of the bundle branch block. Chest X-ray findings show bilateral infiltrates and some pulmonary congestion. And this is that chest X-ray of this patient. You can see again, kind of hazy with bilateral kind of increased congestion, but no clear pneumonia. It's kind of a typical finding of a child with RSV and viral infections in the winter. The post-op tetralogy flow was intact, and there was normal biventricular function with no residual defects. The troponin levels were markedly elevated at about 100 here, and cardiology was consulted for the kind of the interpretation of the troponin elevation. The differential would include potentially myocarditis, I guess, affecting even a child who's had congenital heart disease, whether there's some residual structural defects, which would be unlikely based on the echocardiogram. There's heart failure, but again, in the setting of normal function, this would be unlikely. And a viral infection, really probably the most likely diagnosis here is that you've had congenital heart disease, it's repaired, and then like many children who have complex medical conditions, they may be more predisposed to picking up viral infections and having more difficult experiences with their viral infections. And so when it comes to actually looking at troponins in the management of children with congenital heart disease, this is, again, a small number of studies exist looking at troponin in CHD patients. There's a number of challenges that exist with regards to upper limits of normal, differences between the lesion types. So not all congenital heart diseases are the same. There are some that are single ventricles with more RV predominance. There's pressure-loaded lesions. There are volume-loaded lesions. And so they will all have different impacts on myocardial stress. Again, troponin is unable to differentiate really the severity of disease in congenital heart disease. And timing in relation to repair may be important because especially the effects of cardiopulmonary bypass. And again, if there are residual holes or defects, sometimes there are small holes or residual defects that are left behind, and this may cause additional pressure or volume loading to the heart, which may impact what the troponin would be. There may be some role for troponin levels in adults with congenital heart disease, and these elevated values may be seen in stable ACHDs as well too. And every patient may end up becoming their own control in some of these patients. So maybe getting a baseline on them at some point and then looking at what the changes occur when they are ill or older may be of utility. But it just speaks to the kind of the challenges of interpreting troponin in congenital heart disease. And one of those clinical contexts that we try to encourage our emergency room partners not to send often in children with congenital heart disease, because if it's a first-time value, it's unclear what to do with that result. I'll give a fourth case of a preterm newborn with a perinatal asphyxia. So a 20-week gestational age baby weighing about 1 kilo and born flat after the C-section. It's admitted to the NICU and is mechanically ventilated on inhaled nitric oxide. This baby is hemodynamically unstable on ventilators and inotropes. The ECG shows sinus tachycardia. The chest X-ray has the ground glass appearance of respiratory distress syndrome. The echocardiogram shows a normal structural anatomy, and in a preterm infant, it's not uncommon to see a patent ductus arteriosus, which will have shunting from the aorta to the pulmonary artery, or it can be bilateral if there's elevated pulmonary artery pressures, which is not uncommon in preterm infants. And so what we measure often to look at the elevated pressures in the lungs is the RVSP, or which is the right ventricular systolic pressure, the pressure that the right ventricle is seeing from elevated lung pressures. So it's a heart under stress, under volume loading conditions, but also a very sick child from just the traumatic effects of a difficult delivery. It would not be surprising in a child like this to have an elevated troponin or BNP level. And so the differential here would be perinatal asphyxia in a preterm newborn with, comorbidities like pulmonary hypertension, respiratory distress syndrome, hemodynamic instability due to a large PDA or a moderate PDA, and possibly sepsis or infection. The repeat troponins are done and they continue to be elevated. And again, it's unclear if this is related to initial birth insult or PPHN, which is pulmonary hypertension in the newborn, or presence of a large PDA. And so these can all be, again, like I said, stressors on the myocardium and may result in ongoing release of troponin. But it's unclear as to how to interpret that elevated troponin in this particular condition. And so there is a role of biomarkers in preterm infants with persistent pulmonary hypertension of the newborn. Troponin T has also been looked at biomarkers in neonates with perinatal asphyxia. The diagnostic value of troponin T levels in the determination of cardiac damage in perinatal asphyxia. This is a study in 30 newborns that was done. And again, there was some role with regards to diagnostic value of elevated troponins, and there was also some correlation with poorer outcomes, and those with the much higher troponin levels tended to do more poorly or have lower cardiac output and lower stroke volume. But also it'd be unclear to know exactly, because there are age-related changes, as Dr. Apple had mentioned, and specifically even the preterm baby versus the term baby will have differences. Those that have had difficult births, and we know that troponin levels can be more elevated in the first 12 to 24 hours after delivery, but that they can be then much lower or even normal in some babies after 48 to 72 hours. And so I think age, not just in the big picture of the lifespan of the age, but also even the short term of with regards to gestational age, and then the duration or the timing after birth, and whether you're a newborn in the first 24 hours or if you are a 1 week old or 2 week old, all have varying effects on cardiac biomarkers, which makes that clinical context essentially important or extremely important in interpreting the biomarkers alone, and really has to put in the big picture of the patient in front of you. Again, let's just shift gears a little bit here and as I kind of wind up and talk about the use of troponin in other conditions, so in cardiomyopathies. High sensitary troponin levels are known to be elevated in patients with hypertrophic cardiomyopathy. The challenges there often is that abnormal troponins were seen in those with higher LV masses and those with outflow tract obstruction. So in hypertrophic cardiomyopathy, the heart can be so thick that it blocks the blood getting out of the heart. And so we know that troponin can be elevated in that group. However, in those that experience a sudden cardiac death, you can have a normal troponin. And so again, I think it's still unclear that, in hypertrophic cardiomyopathy, how to interpret a troponin. It may be, again, as I mentioned earlier, that every patient may have to be their own control, and that you want to know what the baseline is when they're well or less severe, and that over time, when they become more severe or have an event, what the troponin levels were at that time. For children with dilated cardiomyopathy, troponins were noted to be higher in those with myocarditis than DCM. So many kids with myocarditis can go on to develop chronic heart failure and turn into a dilated cardiomyopathy phenotype. However, the study by Jeff Gossett and colleagues showed that left heart catheterization was in 24 children with cardiomyopathies who had troponins done. In no case did it make or change the diagnosis, and children with elevated troponins differ from adults. And so I think, again, interpreting the results of a cardiac biomarker in conditions where you don't have clear-cut baseline or understanding what the context means can be challenging. And so it can, again, be a diagnostic tool, but serial testing may not necessarily be very helpful. And one other form of condition that can have a cardiomyopathy is the use of troponin in neuromuscular conditions like Duchenne muscular dystrophy. So males with Duchenne muscular dystrophy can present with acute chest pain events and elevated troponin with really no coronary artery involvement. This may also be seen in asymptomatic patients, and that this does not seem to correlate with cardiac MRI assessments of cardiomyopathy, but has been seen in those that have had some late gadolinium enhancement changes on MRI. And so again, further understanding of what troponin level changes in Duchenne muscular dystrophy are needed, especially in the context of future drug trials or gene therapy, because this is a group that's undergoing quite a bit of either new drug or gene therapy exposure. And the trials often include troponins as one of the biomarkers. But again, having a clear understanding of what it means at their baseline to what it would mean after they've been exposed to an investigational drug is an extremely important important concept for us to all develop and understand. And so, in summary, troponins are a valuable diagnostic and potentially prognostic tool for children with heart disease, and especially, I think, in conditions like myocarditis or in coronary diseases like AOCA or even Kawasaki disease. However, the role in those patients with congenital heart disease and in other populations with comorbidities, things like prematurity or post-surgery, it's unclear, and there's lacking validated norms in these groups. The clinical context is essential when trying to interpret an elevated troponin, and really there needs to be further validated work in other populations and more investigations in various disease groups to get a better understanding of what the baseline and what the elevated levels mean. And there may be actually also be some role of AI and machine learning tools in this, where troponin levels can be incorporated with other diagnostic tools like imaging modalities and physiologic parameters that can then be put in together in different weighted models, and may add some further sophistication in diagnostics and perhaps in prognostication as well too. And since May the 4th just went by, and I'm a big Star Wars fan, I thought I'd end here on a belated May the 4th for everyone. Thank you. I'm going to stop sharing. Okay.
Great. Thank you so much for that great talk and the segue into the question and answer session, which we now have about 13, 14 minutes to take questions, which you have been submitting throughout the webinar. Thank you for submitting those great questions. We're going to jump right in, and we don't have Dr. Mills here, obviously, for questions. Whatever questions we can't get to, we'll send to the appropriate professors, but we have experts here regardless on sex differences as well. I'm sure Professor Apple can take some of those questions. So I'm going to jump right in, and feel free to keep throwing questions at us. But one question that we have, do we advise using sex-based reference ranges or the 1-2 hour troponin protocol in detecting acute coronary syndrome? Fred, do you want to start with that one, and I can offer my input as well later if necessary?
So, yeah, I think what you're talking about, the earlier rule-out protocols, correct? And the earlier rule-out protocols are not based on 99th percentile URLs. They're based on a optimized low concentration at the limit of detection or slightly above that provides a 99.5% negative predictive value and at least greater than a 98% sensitivity. You always want to minimize any adverse, events out 30 days. So I would say that there are no sex-specific cutoffs to be used at the low range. They work pretty much the same at the low end for ruling out. And if you a single sample might miss some, so a lot of places use a 0-1 or 0-2 hour protocol and develop a delta assay dependent to assist in ruling out. So they're independent of age. They're typically independent of sex, and it's just a derived 0 hour that is usually validated, and then a derived 0-1 or 0-2 hour, which are both recommended by ESC. And that's the way I think that works out.
Yeah, I agree. Kind of two different things. You can use the accelerated diagnostic protocol using very low limits to get someone out quickly, but to rule in the higher sex-specific URLs, basically. So you can implement both of them, I would say.
Yeah, just Laurie, one comment. In those early rule-out protocols, there often is they usually use about 70% positive predictive value to assist, not to rule in, but predict likelihood of having an infarction. And those are, again, assay derived and have nothing to do with the sex-specific cutoffs. It's a number that says if you come in with a 100 nanogram per liter or 200, you're at a high positive predictive value. So again, those are independent from my perspective of using 99th percentiles.
Excellent point. Dr. Gio, you made a comment several times that every patient, perhaps for congenital heart disease patients, should perhaps be their own control or baseline. And I guess this is a question actually for both of you, it would appear to me. Doesn't this make sense for perhaps everyone, adult heart failure patients, but maybe everyone, to be their own cut point when we've talked about differences in sex, differences by age, and differences in the setting of comorbidities?
I'll take an initial stab at that, and I think I'd love to hear Dr. Apple's opinion on this as well too. I think one of the biggest challenges, though, if we use the example of congenital heart disease, and let's kind of go through even a little bit of the life cycle that you just presented. If we take say an infant who has a VSD, a common hole in the heart, if you measure, let's say that's the baseline to measure the troponin, then, well, that's still a pressure loaded heart. That's a heart that's kind of been under stress. The baby may have failure to thrive at that time, poor feeding. Like there's a whole clinical syndrome there that is not normal. It's not a quote unquote normal baby. So you would have a troponin level at that time that would be reflective of that clinical state. And then they would go under bypass, they would have a surgical repair. And at some point, if we can imagine that they're in a more normal physiologic state. But, again, if you got a troponin then, well, that would be their new normal, but you'd have nothing. The previous one wouldn't be reflective of a reasonable comparator to them. And then that child goes on to say, either have a complication, say they develop heart block or some arrhythmia. Then again, you've had something else that's changed. So again, where would the baseline be? I think is a bit of a moving target. And if they go on to become an adult with congenital heart disease, and they have the aspects of, I guess, cardiovascular risks that develop from whatever their lifestyles are, eating, and then I think they have a new normal. So even I think there is value in coming up with trying to having every patient have their own control. I think, again, it's going to be difficult to interpret, because when you do that, will also differ in age-related changes and the physiologic changes for those patients. And then it's really going to, I think it'll be difficult for a lab to be able to tell you what this means for this patient, so that if that patient comes to the emergency room for any kind of complication or sequelae, how to interpret that value. So I think it's just difficult. That's my stab at that.
Yeah, I'll comment just briefly, and then I just want to ask a question also, Lori. So children, there's not enough database, and what we're moving towards and possibly implementing is this machine learning, artificial intelligence. We're not just using troponin on an individualized, personalized medicine routine. There's 3 well-known published studies out there called MI-Cubed, Artemis, I think it's Code ACS, where you take a series of other parameters. You take age, gender, sex, renal function, and they let the machine learning do its thing, and it gives you a personalized score of what your risk is of having myocardial injury and maybe even myocardial infarction. So I think as far as adolescents and pediatrics, that has not been explored in any large databases, but I think there's a potential future for that. And that gets away from the absolute concentrations of different assays. If I could just transition to one other thing for our pediatric cardiologist, is the one comment he made, which I think has to be clarified from a laboratory point of view. I think your last case, you touched about muscular dystrophy and the use of troponin, which is, I think, great. But when you're using troponin T, which I understand that's what your lab is using, the user has to be aware that in neuromuscular diseases, there's the potential that cardiac troponin T could be expressed from skeletal muscle and regenerating muscle from neuromuscular diseases, and that the troponin T may not be a good signal to follow heart injuries. And you might use a troponin I assay. So that has been published in the literature across many sites around the world, of the concern that there may be low false positives, not from the heart, but a false positive signal from neuromuscular disease or things like muscular dystrophy that are not real for cardiac troponin T. So I think you need to be aware of that yourself. I mean, you're okay?
Yeah, no, that's a great point. Thank you. Appreciate that.
Yeah. Fred, I think you touched on some really important points, mentioning AI. That was another question that was submitted on how it may impact our diagnosis and use of troponin across the life cycle. I think that's a definite possibility. Another question why do infants and newborns have higher troponin? Do we know the answer to that?
So I'll just make having looked at this, there's some really good old research on newborns, and that the thought is a lot goes on, and I'm not a clinician, but there's a lot of things going on in a newborn heart that is maybe still has I don't want to say a growth phase, and we know larger hearts have larger troponins. If you look at reference ranges, i.e., the size of the heart for women is smaller than the size of the heart of men. That's why the concept is thought that there's a difference in sex-specific ranges. I'd have to refer to an expert as Dr. Jivas to say, in newborn, the heart is still going under probably some trauma. This is just my guesstimation, and what the mechanism of why it's higher. But at one point, things settle down, as let's say the caliber study showed. The heart then kind of stops its growth or whatever. This is all hypothetical, just thinking from what happens in physiology. And then that's the reason. So it's a moving target. If you look at the literature, the numbers are all over the place in newborns and neonates and even in early adolescence. So I think what I've heard his presentation say is it's not so much to diagnose an MI. You may get you want to just see what's going on. I got a lot of questions from ER physicians at our children's hospitals. Should I use a point of care test or as a central lab test? I think you're trying to just get an idea is, hey, is it really elevated? Not if it's 15, the normal range is 14. I think you're looking for a 40 versus a 14, and I'll stand corrected. And then you try to follow the patient from there. Does that make some sense, Amir?
Yeah, absolutely. So, I mean, I think the colloquialism is that being born is hard. I think the shift from a fetal circulation to a postnatal circulation, there's actually quite a bit of hemodynamic stress that goes on in that phase. To go from a fetal circulation where you're basically more on a right ventricular dominant circulation, and then you're born, you take your first breath in life, your pulmonary vascular resistance starts to drop, but it is not normal compared to an adult pulmonary vascular resistance. You have this presence of a patent foramen ovale, you have a PDA, so you have both pressure and volume loaded changes that are rapidly occurring from the minute you go from a fetal circulation to a postnatal circulation. That form of myocardial stress is, and I think an obvious source of where troponin will leak more than, say, someone who's even a month old. And so, I think for those kind of variety of reasons that being born is hard, and the amount of myocardial stress that occurs in that first period of time is not insignificant. And then as the postnatal circulation starts to settle out, the pulmonary vascular resistance starts to drop and become more normal. The PFO closes. That's the reasons why troponin becomes more age appropriate as it goes further along. And then you compound it by any additional stressors like congenital heart disease or birth asphyxia or preterm babies, and then you end up with more challenges. So similar to what you just said, I think there's a signal as a tool when you have challenges to use the troponin, but I think it's hard to interpret, and you really need that clinical picture.
Hey, so I just got to poke you once is be careful using that word leak. There's a troponin leak. Now, maybe you believe in reversible, but when you hear the word leak, I think I can put a patch on it and it's not irreversible. Sure. So I think unless you believe it, be very careful, because you don't want to influence your colleagues to think that there is evidence to say there's leaking troponin. All right.
Yeah. Excretion.
You can say release.
There you go.
We only have a couple of minutes left, and we have a lot of really good questions. So I'm trying to pick some here that you can answer in about a minute. Now that may be a stretch, but how do you envision troponin fragments might impact MI diagnosis, more as an add-on test or a replacement for traditional troponin? And is there data that they differ by sex or by age?
Yeah, so real quick answer is if it gets to the point where we have automated assays that can measure, let's say the complex. The complex is let's say the long T complex, at least that one study that was published in ClinChem. That is a form that has not been fragmented. So if I'm looking at typically you see very, very low levels of the complex in the circulation. If there's an acute injury, it goes up in the ratio. You look at a ratio. The ratio of the complex to, let's just say, the troponin is very high. So I think it will work very well to discern acute from chronic injury. All right. Data has to still be done to say, we'll differentiate type 1 from type 2, and then the kinetics. So there's some promising early evidence. Will it be an earlier marker to make a diagnosis? Well, we all know we need some number to say a rise and fall above. So we'd have to see what the data starts to show.
Fantastic. Well, we are at our time limit. I want to thank you for attending this webinar. Thank you, Professor Mills, who could not be here, Professor Apple, and Dr. Jiwa for your very interesting presentations, your excellent Q&A and discussion. I very much enjoyed that provided such valuable information on this topic. And of course, thank you to the IFCC for offering this tool for the e-learning. Couldn't do this without that. Please remember, if there are unanswered questions, and there are quite a few of them, I apologize, I couldn't get to all of them, they will be replied by email to those who pose the question. The certificate of participation will be provided at the end of this webinar after you answer a few questions. So at the end of the questions, please click Show Me My Scores at the end of the page, and that's how you get your certificate. The IFCC live webinar is designed to be completed within 90 minutes. We'd pretty much hopefully hit our goal there. To earn CE credit, participants must complete the activity online. You need a passing score of 75% on the post-webinar quiz to get the 1.5 CE credits. And last, the on-demand content of this webinar will be available shortly, and you'll be informed via email. There are soon going to be other IFCC free webinars, and they will be announced by the IFCC communication channels, email, website, as well as IFCC social media. So thank you so much for your participation. We had a large number of attendees. Thank you to my speakers and everyone. Have a great day and evening.
Thanks, Laurie.
Thank you very much. Bye-bye.
Bye.
Thanks, IFCC.